didn't know it was possible for a human to die so horrifically and so quickly before they rolled out the mRNA injections. Some of these cases, like their family would be there 30 minutes before, and then within an hour, they're dead.
Welcome to The Last American Vagabond. I have a special interview today with Zowe Smith, former medical coder, medical whistleblower, here to discuss some of her observations around this, having a very special inside perspective of a lot of the things we've discussed around COVID-19. Most importantly, around the interesting shifting around the codes, the ICD-10 or now ICD-10 codes that were used to categorize the different vaccinations, the different treatments, the different side effects, and a lot of this, but was interestingly shifted during COVID-19, like seemingly everything else, but also a lot of her interesting observations that she personally saw. And she'll have an interesting perspective about this in regard to why the coders themselves seem to have sort of, as she framed it, a sort of Sim City view of all of the different categories, all of the different agencies, and the recording of this data. And it aligns with pretty much everything a lot of the people were trying to highlight right in the beginning and all the way through that many still have yet to actually come to terms with. So Zowe Smith, it's an honor to have you on the show. How are you today?
Thank you. It's an honor to be here. I'm good. How are you?
You know, good in general. I think there's a lot going on. It's always the whole, all things considered, where we are right now. But, you know, I do think that there's a lot of things to be positive about, a lot of awareness around, you know, because of people like you. So we always have to point that out. So today, let's kind of start with, you know, the background around this, and really start wherever you'd like. But I do think it's important that people see and understand, you know, your journey through this understanding and what it was that stood out to you the most, and the moment that you decided to sort of buck the system. Yeah. So start wherever you'd like.
Okay. So right from the very beginning, when they said Wuhan virus, I thought this is going to be another SARS or H1N1 or swine flu. I had worked in healthcare for a long time before I was a medical coder, so probably like, you know, multiple decades. And those were never like really a big scare. They, you know, the media talked a lot about them, but we did at the hospital, we didn't really see a lot of patients that matched what the media was talking about. So it was kind of like we talked about it in the hospital, but we didn't really talk about it outside the hospital, that it really wasn't a big deal. And even since then, I've spoken with people about that are, I don't know, more closed-minded about what we're talking about, let's say, that are still in the medical field, that would even tell you that they believe that they were not really a big deal. And I even spoke with like a ER doctor and a nurse practitioner that worked in urgent care, and both of them said that, you know, they personally got it and it wasn't a big deal. You know, they were back at work within a few days. So, so then 2 weeks to flatten the curve happened, and the executive orders came, and I thought, well, this is going to be terrible. And I started, you know, spreading the news right away, and people weren't shocked about it. People were going along with it. So well, I pretty much felt like right from the beginning.
Right there, when you say spreading the news, though, so what were you seeing? What was happening? So again, as a medical coder, somebody
I was not seeing any cases in the hospital when they had the 2 weeks to flatten the curve. There weren't any cases in the hospital. We had like a couple what they might call flu cases, because they were really watching for it from, kind of like you had been talking about in your show, from like November 2019. They were watching for this Wuhan virus to come. So any sort of flu, they were wondering, is this the thing? And we didn't really see anything like that. It was just, you know, regular. There might have been like a couple weird cases here and there, but nothing to really make us go pandemic.
And so when you say
And even
seeing,
when
you're
2
talking
weeks to
about,
flatten the curve happened, we didn't see very many cases for probably weeks after that. So
and real quick to jump in, when you say seeing, you're talking about seeing the codes come in through the coding when
I'm
you log
talking
in.
about seeing cases reported in the hospital. So every patient that comes through the door, not only do they have a census of how many people are in there for anything, they'll have like a count of how many outpatient services they do, and they have a census of how many inpatients that they have, and that has a lot to do with staffing and budgeting. So every part of the hospital has to know about the census and when it goes up and down. And especially in the region where I was in, it was very seasonal. So we would have, our busy time was always the winter because our population would double in the winter, or at least we would have an additional population in the winter. And then in the summer, they would all leave. So we were always paying attention to the census, and we'd have to like change staffing and everything accordingly. So when pandemic was declared and we don't see anything in the census saying, there's anything like that. And then additionally, as medical coders, we have to put a code on every single patient that walks through the door, whether it's an outpatient service, an inpatient service. If they just come in for an x-ray and they go out the door, there's a code for all of that. And it's all about monitoring disease trends. That's what you do all day. That's the entire purpose of it. It is a statistical monitoring system. That's what it's been since its inception. It actually was created out of a statistical society, which eventually ended up in the hands of the WHO. They're the official host of the ICD-10 codes. They're like the ones at the top that get to distribute how it works. They're like the ultimate deciders of how it works. And it's always been about tracking disease trends. It's how they track cancer. It's how they track HIV. It's how they track any diagnosis.
Well, let's talk about the codes then. So, because even from my knowledge here, so I understand it, because I think so in regard to the actual process of the job and then what the codes are, why don't you explain the audience for how that works? So is it just you getting information on pieces of paper and allotting codes to it, or are you physically there seeing things? Explain that for us, and then what the codes mean.
So I worked from home primarily. Most medical coders now work from home. However, I did work in hospitals at different points in time. Sometimes if you're in management, or depending on whatever your job position is, sometimes you do have to be on site for different things. So I mean, I've done things like watch procedures be done, and gone to seminars and different things at the hospital. So I had my foot kind of in both doors. Although during the pandemic, I wasn't in the hospital. I wasn't physically seeing it. I was just watching, the census, and just in the process of doing my job, which was not only monitoring the census, but looking at what diseases are coming across my desk every day. I mean, it's just, if you work at McDonald's, you kind of get a trend for, the people that come in for lunch rush and who are your regulars. It's kind of the same thing.
Right.
So we weren't seeing any sort of, flu or COVID or anything, even, much after when they declared 2 weeks to flatten the curve. And so that was obvious to me just because of the position. So what we actually do is you look at any sort of paperwork that's created. So anything that you go in and you do with your doctor, there's going to be paperwork. So the nurse is going to ask you a bunch of questions. That's going to be a document. The doctor's going to talk to you, and they're going to do an exam. They're going to document all your vitals and everything that they told you. If there's an operation, they're going to write down everything that happened during the operation. For the x-ray, there's going to be a picture, and then there's going to be a read from the radiologist, and that's going to become part of the record. So like all of that information, in addition to a bunch of other kind of monitoring and financial information, kind of gets layered together. And you're only supposed to have access to the information that's required to do your job. But in order to do our job, we had to have access to all of these different pieces of information.
And so the actual codes themselves, explain that for a moment. The idea that so the ICD-9 or now 10 is a kind of continual process that's always been there before COVID-19, but something shifted around this. Now, if I'm jumping ahead too far, let me know. But so something shifted in regard to the code.
No. So right after 2 weeks to flatten the curve, it was the CDC announced and the AMA both announced that there was going to be a new code for COVID-19 because insurance companies had been writing to us saying, do you have any COVID patients? There's actually bonuses, but you have to bill it this certain way. But it was against coding guidelines to do that. So that would be committing fraud if you go against coding guidelines. It's almost like it's not a law, but that's if you don't follow them, that's how you end up having to pay fines and you end up in court. So you want to avoid that. That's the whole point of medical coding is all of those codes, especially in the US, they don't just track diseases, they also track finances. So they all have like a monetary value and they go out on a bill to insurance, and then insurance pays you on those diagnosis codes. So they end up having a monetary value. Even in other countries, they have kind of an indirect monetary value because their system is set up in a way that mirrors the US, but it's not directly tied to payment in the way that it is in the United States. But because it is in the United States, we could only report a junk code. It was like just unspecified flu. And there was no way to get the bonus for the COVID patients for the pandemic, because they could already see that the CARES Act was coming into play. They were talking about publishing it, and there was going to be bonuses, and we couldn't get it unless we billed it this fraudulent way. And so there was in the coding world, there was a big talk about, well, should we do this? Should we not do this? Because there was the incentive there.
Yeah. Is that normal?
No, that's not normal. And then April 1st was when that code went into effect. So that was when the code U071 COVID-19 came out. A couple other codes came in with that right around that time. So that is outside the normal time. That was unprecedented. That's their word. I hate that word, but it does actually apply here. That had never happened before. There's only 2 times a year where we do updates. It's a big deal because all of the computer systems that interface with the codes, all the billing systems, all the input systems from like the diagnostic people and nursing and doctors and all of the programs that they use that input that data that comes to us, there's an interface that all has to match up. It's a big deal to do that. So we only do it once a year for diagnosis codes and once a year for procedure codes. And that was not even the scheduled time to do that. We had already just done it in October and then in January. And we were supposed to stop until the next year. And so April comes and we have this new update. Well, with that came the CARES Act money. So we were able to, bill for COVID-19 all of a sudden, and we were able to track it. And right around that time, and we didn't really have any patients in the hospital, as I said, like right at the very beginning, but there was a thing that coincided, and that is the PCR test and how that evolved.
Right.
Because right around that time, there was a bonus in there for COVID-19 testing with the CARES Act. And so there was codes for the COVID-19 testing also. There were codes for like exposure to COVID-19, contact with people who had COVID-19, and that was for the contact tracing portion of it also. So it wasn't just the COVID-19 code, but that was the whole point, was to have a way to track that. The way the PCR test evolved, normally at the very beginning of the PCR, or at the very beginning of the pandemic, they had like tents set outside and you had to have symptoms in order to get tested. I remember even like ER doctors and nurses that were my neighbors that I was talking to in real life that were in the hospitals physically seeing all of this. They said patients would come in and beg them to get tested, and they couldn't do it because the testing was limited. And at that time, you had to send it to the CDC, and the CDC took like a week to turn around and get results. So if you happened to be an inpatient at that time, you would be admitted under quarantine for a week, waiting to get your test results. And then, patients outside that they had to have symptoms, and then if they got tested, then they're supposed to come into the hospital. We had to test them again. Well, that normally costs money.
Mm-hmm.
Well, when the CARES Act came around, we got paid to do it. And the testing evolved to where now you don't need to have symptoms. Now everybody can get tested. And that's about the time when the patient population that we had went from almost nobody had it to about 80% of patients now come up positive for COVID-19. And
let me
so
point
that
out a couple of quick
started a
obvious.
whole
Yeah, let me point out a couple of quick obvious things which you're highlighting here. Which, first of all, I think it's obvious that we should recognize that what she said there is that the shift to the ICD-10 from the 9 usually happens at a different time. This was jammed through at a time it didn't happen in the midst of a supposed pandemic, which you could tell me whether I'm wrong on this. I think guarantees there's going to be some confusion, some mistakes made, right? That kind of seems like one point. Go ahead.
Part of it, yes, for sure, the confusion. It wasn't the update from 9 to 10, though. The update from 9 to 10 happened in 2016. This was just an update to the ICD-10 code set. They do it every single year.
I guess
this
what I'm saying is
outside the normal scheduled time.
Yeah, I guess what I'm saying is the 9 to 10 was the normal timing process change. The one you're discussing was done outside of that normal loop. Is that correct?
This was outside the normal time.
Yeah.
Correct.
And then the other part of it you're describing there is the interesting point, which it's very, very clear that there are bonuses, which even Michael Jensen called out early on and lost his practice for highlighting this provable fact, that clearly, I don't know, I think it's obvious to point out is an incentive to then make it COVID-19. And, pearl clutchers out there would say, how dare you suggest a doctor would do that? But the obvious point is that you can come down to a line where it's not even in their mind a dishonest thing. You're on the fence and you go, well, let's lean into COVID because that, gives us more money. That is something that's absolutely happening with the PCR test false positives that we can all verifiably prove today. As she's highlighting, it exploded into the COVID-19 pandemic, the illusion therein. And I think that's really interesting. So that's right there.
We started to get patients is when we had testing.
Do you feel that was deliberate at obviously I think it's clear that my opinion is there was a deliberate action there, but to what degree do you think that was deliberate within the medical system, and how many people called that out at that time?
Nobody called it out, and I think it was 100% deliberate because somebody at InfoWars pointed out that there is a ICD-10 steering committee. So they talk about these codes and how they're going to update them every year for months. I mean, there's a whole lot of red tape and bureaucracy because that is how they work. They have to work with a lot of organizations. I mean, we're talking the people who create the codes are like the WHO, the AMA, the AHA. There's I don't know, 5 or 6 of them. I'm probably not even remember. AHIMA is one of them. So all of these organizations have a stake in it, and they all have members at this committee, and so they all have to argue about how we're going to do it. And there has been times when we've needed a code, and over 4 years we still can't get one simple update, and all of a sudden we have, in less than a month, we have a brand new code. And even our management is telling us, and I'm sure this wasn't just my hospital, it's probably all over the country. I know a lot of coders that do work all over the country because I was doing contract work and working with them, and they were all saying the same thing, that their management, they didn't know how really to handle this fast, that they were totally unprepared to do this massive update, and they had to just follow the CDC guidelines, and we were given, this is how you're supposed to apply the code, and it changed everything. So with someone that used to come in with the flu or pneumonia or bronchitis or anything else that might have been attributed to some other upper respiratory type of disease, now it's sequenced as COVID. Well, the COVID code itself was meant to be a viral code. You weren't supposed to put it as a primary diagnosis. It had no monetary value to it. You were supposed to put the disease first, and then the virus is additional information. And there were big billing edits that you couldn't even send a chart out the door if you put this virus code as your primary diagnosis. It was a big no-no. And it actually said right in the guidelines, this is an exception to the rules. And the only other exception is HIV and Zika virus, which I found to be pretty suspicious because they were already talking about Dr. Anthony Fauci and that he might have been, I don't know, people just didn't really like him. And I didn't had no background information on him. I didn't follow any like mainstream media at the time, but I definitely got a feel that if he had a hand in it, and these are the diseases, that might be an indicator of why this is the only exception. And then I looked at and found that they had been studying that at the NIH. Now, the interesting thing about it is that the guideline says that the doctor's professional opinion is the only thing required to make a COVID-19 diagnosis. That's the exception. So for every other diagnosis, you're supposed to have a clinical indicator to back it up. Like, so if I say someone has anemia, then I have to have blood work that shows anemia. I can't just, even as if I were, I'm not, but if I were a licensed physician and I were trying to make a diagnosis, you can't just write it down. You're supposed to actually prove it too. That's one of the things we were supposed to look for.
Well, what was the stated logic there? That's quite a shocking shift from needing to prove what's happening versus just, with how much pressure was there. So was there even a stated logic on why that happened?
No, and everyone was questioning that because we're not supposed to do that. And so our hospital, and I don't know if it was like this for every single one. I think every hospital might have made their own individual policy because everything happened so fast. They were just thinking on their feet. But our hospital was like, well, we don't want to get sued. So, I mean, you can actually see there's a blog about coders from the AMA and the CDC, and they're talking about how to use these codes, like right about when it comes out. And so they have like a update and a Q&A. And they'll have a date and a question, and then their response to it. And everyone was writing in with, how are we supposed to handle this? It says if the doctor says they have a COVID, the patient is COVID positive, then we have to call it that. But we didn't do any testing, or the testing doesn't match up. And is that like a legal liability? Can we get sued for that? Are we going to have to pay fines for that? So, yeah, that was definitely very different.
Which obviously we should make sure people remember that they then, I don't know if it was then or before this, but at some point in that process, they basically indemnified every single angle of the entire, which I, made jokes about this in my show, where if the nurse tripped and poked you in the eye with the syringe, they wouldn't even be able to sue because they literally protected the delivery, the actual administration. I mean, which is wild and unprecedented, so that seems like an obvious point right there to, allow this unverified process to just be taking place without any checks and balances around it, or even legal action around it. I mean, I think I don't need to sell our audience on how this feels like it's deliberate, right? I'm sure your writing has covered that as well. It seems like every angle of this was done to almost maximize the problem, which, let's actually get into that then, in regard to, before we get into the tracking part of this, which I really want to highlight. So now you're there and you're watching this kind of explosion, perfectly correlated with the administration, with the PCR test, with everything that's happening. And so let's go into what you were actually seeing, what we kind of highlighted there in the beginning, and give me any other thoughts you have about how it relates to the process itself.
So after, I would say like maybe late summer is when we started to get patients like trickling in. So this was after like months and months of lockdowns and wearing masks everywhere and quarantine and all of that. Then we started to actually get more and more patients in that were actually COVID positive. Now, I had already stopped paying attention to if patients were COVID positive, because it was very obvious to me. I'd worked in a lab before. I understood how that worked. And I was looking into what is going on with this PCR test, because people were already talking about there was fraud. So what I was seeing in the hospital, there is not a pandemic happening. There's no flu going on. There's not a lot of sick patients. There are a couple weird cases where there's patients that were clearly with some sort of flu-like symptom that made them go to the hospital. And when we came out with the COVID diagnosis code, that is also when, right around that time, there was a weird Operation Warp Speed came out with, we're going to deliver hydroxychloroquine to hospitals. But the interesting thing is, hydroxychloroquine is Plaquenil, which we already had for different things. So we just didn't use it for COVID until we got this stockpile thing. And then a few days later, they stopped that and they came out with remdesivir. Well, they also came out with 3 other drugs, and they had other treatments for COVID. So they had convalescent plasma, they had monoclonal antibodies, and the remdesivir, and I think one other drug. All we tended to use was remdesivir, and I couldn't figure out, well, why do we use remdesivir and just remdesivir? And it said right in the directions, like there's a protocol, and you're supposed to check and make sure the patient doesn't have any sort of kidney failure. If it's too high, you're not supposed to put them on it, and you're supposed to monitor the kidneys while the patient's on it. But we're also being told that COVID-19 causes kidney failure. So as patients that do have these symptoms that come into the hospital, then they go through this COVID protocol and they get put on the remdesivir, they get put on the vents. They end up on the vent for a really, really, really long time, because normally we don't want to keep a patient on a vent very long. Like normally they're talking about, putting the patient, sending them to a skilled nursing facility or weaning them or, something, unless there's extenuating circumstances. But it's rare to have a patient on a vent in the hospital for a really long period of time. It's usually only a few days. So to have patients that were on it for months, I even heard Dr. Pierre Corey say that, he's got COVID patients on vents for, 30 days. And I'm like, I can confirm that was happening. And that was not normal. Yeah. So clearly there was something happening, but it wasn't like pandemic level happening. So I automatically thought there's something going on with how they're treating these patients. And of course, they're saying we're experimenting on people. This is COVID. We don't know what's going on with COVID. We're just trying things. And at a certain point in time, I had already started to hear, this is probably late summer still, I had started to hear that patients had been dying on vents, just through, I don't know if I heard it on InfoWars or if I heard it just through, like at the dog park or something, but you hear rumors just being out. I didn't even watch mainstream media anymore, but I could clearly see there's something going on with events at the hospital. And then we get this note from leadership one day, and it says, we're experimenting with how to treat COVID. And they had been trying, ECMO and different things. And they were talking about it in the news, like their articles, and everyday leadership's talking about we're experimenting on blah, blah. And this is working and that's not working. Well, one day they come out with this note that says there is these FiO2 settings on the vent, and that's one of the vitals, or one of the monitor things that they record in the record on a vent. And they said the setting was killing patients. And so, we're sorry, and we fixed it. And so we learned our lesson, and that's not going to happen anymore. And I was just shocked by that, because I thought, oh my God, that's pretty much confirms what I had been suspecting and what I had been hearing rumors about. And then, so I started asking around to see if anyone of my coworkers had heard that, and they hadn't heard that. So the next day I go to try and pull the article and send it around to everyone in case they missed it. And it wasn't there anymore. I couldn't find it.
Yeah, the ventilator aspect of this, Dr. Artis, who I interviewed about this in general, said the same thing as well. The overlap with the remdesivir administration and the ventilator, as well as a few other aspects, almost, when looked at objectively, are almost designed to lead to this outcome. Dr. Seidel from New York City famously kind of spoke up and called this out, and said, we're not treating this properly. He said it's a medical paradigm that's not correct. Like, he was very clear about what he was seeing, and yet it just all seemed to continue.
Gilead applied for a new tech bonus for remdesivir. I didn't find this out until later. It was actually Dr. Artis that helped me put together what was actually going on, because patients would end up with pulmonary edema, and they were calling it COVID pneumonia. But if you look at a lung x-ray, and I'm x-ray certified, so I do actually know what I'm looking at when I look at an x-ray. If you look at a pulmonary edema patient right next to a COVID pneumonia patient. It's like almost identical.
Mhm.
And the way he describes that, and this was happening with patients who were coming in with fluid overload. Well, typically they're going to suspect something like congestive heart failure. That's the first thing they're going to look at. They don't think the kidneys right away, because normally they already know that the patient's in kidney failure. They work their way up to kidney failure slowly. And so it's sort of expected, like, oh, they missed dialysis. And that's the type of fluid overload they're used to seeing. They're not used to seeing patients just walking in with fluid overload in, like, end stage kidney failure. But the way he describes that the kidneys do regulate fluid, and it can come up through the diaphragm and get into the lungs. I mean, they would call it, pleural effusion sometimes, or it made perfect sense the way he described that. But in the hospital, they were just thinking this is the disease process for COVID-19.
Assuming.
They didn't suspect, they did not put together that the remdesivir, even though they had this protocol of, we need to be careful because it says right on it that it can cause kidney failure. It didn't say it could cause kidney failure. It said it could cause kidney damage. But obviously, patients were dying within 3 days of being put on this drug, like clockwork. I mean, they would get the COVID-19 diagnosis, they get put on the protocol, they get put on the vent, they get the remdesivir, and they circle the drain. I mean, it was like every single time.
This is the kind of, almost willful ignorance that you're highlighting here, is that, right there, imagine being in that position. And yes, I get it that in the mindset, let's just assume that they're honest and we shouldn't be doing that. But in their mindset, they're looking for some new novel thing and they're trying to understand. But having a study that says the thing you're giving them can cause kidney problems, and then watching almost consistent kidney problems and then just not connecting those dots. To me, I don't know how I can make that sound.
I don't understand it either, because they said the monoclonal antibodies, they don't really work that well. The convalescent plasma, like within a short period of time, they're like, that's not really working that well. So they just went into the remdesivir more. And I just had to keep thinking, well, is it because of this new tech bonus? Because they get a 20% bonus every time they give this drug.
Right. I mean, at the very least, you can think that that is something that drove them to, again, even assuming that they're honest, it's still an incentive. And then I'll highlight the New England Journal of Medicine study that most everyone has highlighted that knows this story, that shows you before this process, they already, if you haven't seen this, they tested remdesivir alongside a few other treatments, ZMapp and so on. And if you can see the numbers here, the point is the number of deaths, the total percent of the people that took remdesivir in the trial was 53%. I just don't know how people can ignore something like that, but this is the point. A lot of stuff was ignored around this. And so all this seems to kind of gather into a big pile of, it's hard to consider this not being deliberate, and that's where I'm left with all this. It's almost impossible, as well as the other overlapping of things they chose not to use, like ivermectin and so on. But I just find that really difficult to miss. So if you have any comments on that, go ahead and jump in. Otherwise, I'd like to hear more about the things that you were seeing that you listed off in your discussions, like what's something you said they kind of broadly named sepsis, but seemed like something more, encephalitis, blood clots.
So after they rolled out the vaccine, the organ failure thing, I actually remember seeing an interview. I do have to say that because of what was happening with the ventilators and the remdesivir, I was questioning what was going on. I was trying to look for answers. I didn't know about the alt media, and it was actually finding you and your information that helped me educate myself before the vaccines came out. I don't know, I found you on Instagram. Someone commented, and through finding that, it like opened up a door to getting alternative information that totally confirmed what was going on in the hospital when they said there was nobody there, and then the vent thing, and then the remdesivir thing. So I was really looking for answers. And when I found that, I started looking into, like you were at the time, the clinical trials and the stuff going on with Moderna and all of that.
The science.
So I educated myself because they don't teach you this in medical school. I had a friend that was in medical school. She wasn't looking into this. She was a pathologist at the time. She actually had just finished her residency at North Carolina, Chapel Hill. Anyway, so when the vaccines came out, I had seen an interview with Dr. Dolores Cahill that said, patients might die within a few days, and it might look like organ failure because the spike is going to go and attack themselves, and it's basically going to be an autoimmune thing. And I believe she even said like it might present as sepsis. And it was odd because I did start to notice some symptoms of, or some cases of, they called it sepsis, but this was not like, and normally sepsis is a whole body infection, and you work your way into it. Like most patients don't just show up with sepsis one day. Like they might have a urinary tract infection or a wound or something, and it goes on for a long time, and then it becomes sepsis after not being treated or having a lot of other things going on. It doesn't just happen within an hour and you're septic. That doesn't hardly ever happen. So that was very rare. And then the multi-organ failure, that was really the odd thing, because once again, young, healthy people with nothing going on don't just within an hour and a half go into multi-organ failure and die. That just doesn't happen.
Were these people also being given COVID-19 tests, and what were those results if they were?
So the interesting thing is by then we had been doing PCR testing routinely on everybody for a good long time, probably, I don't know, 8-9 months, something like that. So when the vaccine came out, I started to notice that they had a different protocol for people that were vaccinated versus unvaccinated.
Right.
So if they were vaccinated and they came in with anything after the vaccine, they would run their vitals, and they would say something like, if the temperature, this was the protocol, if the temperature isn't over a certain thing, then they don't have to do the test. So they would just basically have a cop out where they don't have to run the test, so they just wouldn't run it.
In addition to lowering the cycle threshold as well, as I'm sure you've talked about, right? On the one side of it, not the other.
I was going to talk about that too, but
go ahead. Go ahead. Explain that for the audience, what that means.
The cycle threshold.
The lowering of it.
When I was looking into the PCR test, I noticed there's no flu at all. And our hospital was running, because at some point, as the PCR test evolved to being done massively in hospitals, it has to be done on a massive scale. So they needed machines that could run them. And, I used to work in a lab. This was what my mom did for her profession. So I was looking into like, what machines are they using? And I was trying to figure out what's going on with the test. And I found out that they were using a multiplex PCR assay. It comes from the CDC, and there's a video that I found that talks about how to set it up. So this test was run, and what it tested for was RSV, flu A, flu B, and COVID-19. And it only ever came up positive for COVID-19. So they were testing for flu. No one had it. They were testing for RSV. No one had it. Just COVID-19 every time.
Which is abnormal at any point, right? There's usually something that, right?
Yeah. I mean, we never had pandemic level anything, but you would get a sprinkling of those at some point.
Right.
And so to have nothing was statistically impossible. Like to me, that was an obvious indicator of fraud. And so I looked in the video, and I had seen, I think by that point I had seen Derek Rose's work on the cycle threshold. So what that is a point in the test where they take basically a primer and they have it set to a molecule that they're looking for, and then they add the sample and they amplify that. And however many times they replicate based on the concoction that they bake together, that's the cycle threshold, essentially. It's like putting, paper and ink together in a printer, and what comes out the other side. They kind of know what they're looking for, and they just
would magnification
the cycle threshold. In the video of how to set up this machine, it specifically said 45 in the video. Now, I could not see cycle threshold in the records at all. I couldn't find it in any lab documentation. I couldn't find it in any of the reference lab. I couldn't find it with CDC. It wasn't in any of the, like, normally there's a reference range and a methodology and a bunch of like legal fine print in every single test result.
Right.
And that ends up in your permanent medical record. And there was a lot of other peripheral information that was collected with the PCR tests, which is what you want to get into. But it wasn't, cycle threshold wasn't something that I had any access to, which I found to be highly suspicious. And then in this video, I see for COVID-19, they have it manually. There's like a little graph, and they explain that the tech can like move the dial up so that it goes up. And then for flu and RSV and whatever, they just have it like, set to normal. So it would always turn out to be negative. So the higher the cycle threshold, the more likely you are to get junk results. I think even Dr. Fauci had that video, which I believe you've shown probably a million times. Your audience is probably very familiar with it, talking about anything over a cycle threshold of about what, like 35, I think he said, is basically replication incompetence.
Yep. Exactly. Yeah. I mean, so, I mean, from your perspective, one thing I want to point out too is, or at least ask, isn't that the same violation of their guidelines or standards that you were highlighting before, to not include that in the codes that you're being sent? I mean, obviously that's supposed to be included, correct? The cycle threshold and the information around it.
No, the code there would just be a code for running the test. It wouldn't even, you can't even, as a medical coder, you can't even code something based on a test result. So it wouldn't be, it mostly just be for charging purposes, just to track that there was a test done. And then in the record, I mean, there would be a diagnosis code maybe based on it.
Okay. Well, that's good to know as well. But so the discussion is that the lowering of this very clearly created a situation where, I mean, let us put it this way. In your opinion, to what degree do you feel that this was something that was more so than just a clumsy mistake? And why do you think, if it's not, why do you think that?
With the testing specifically?
Like the cycle threshold being altered on one side versus the other, the way that they used it.
I think it's intentional, 100%. I mean, I noticed it even before I knew that there was something wrong with the test. I mean, that's really what woke me up, was the testing part, because I watched it more from a long time ago. It was like when I worked in a university hospital in the lab, one of my jobs was occasionally to process the rapid strep test, and it had to be done within 15 minutes. That's why it was called the rapid flu, not rapid strep. That was a different test. The rapid flu. And it was very similar to the COVID-19 PCR. It was a nasal swab that would be collected, and it just had to be done within 15 minutes. It didn't have the same PCR methodology, because back then PCR was brand new. We didn't have PCR technology at that university hospital. So we had to send it out to a lab somewhere else across town that had that, where we had to send it out to like, main reference lab, like that a bunch of hospitals use, because they don't have the money for all of that equipment if they don't run the testing all the time. So way back then, PCR was brand new and it was a big deal. So I thought I would have known that it was a PCR test, and it was only done as a screen. It would only be on, it wasn't every patient that came in with the sniffles. So right away, when they started saying we have to screen everybody and the swab had to go all the way up the nose, I was already on high alert, because that changed. It wasn't supposed to be a screen ever, and it didn't need to be collected that way. So the fact that they changed that even before the cycle threshold thing happened, I honestly didn't even know that it was a cycle threshold. And I don't think the cycle threshold alone is the only part of it.
Interesting.
The interesting part of it that most people are not aware of is that, so PCR, even Carrie Mullis will tell you that the whole point of PCR is not to detect a virus. It should not be used to detect or to diagnose anything. All it does is amplify a particle of DNA, basically, is all it does. He says you can find anything in anybody, right?
Right.
So those swabs are collected. They are sent to a lab, and each lab is required by CDC to send that information, because they were tracking COVID-19, and this is what the CDC does. So they have databases, they track different things. For things like HIV, we had to send records to them. For things like cancer, you have to send data to them. And so for COVID-19, they created a registry. And for every PCR test, there was a certain set of DNA sequences that had to be sent to CDC.
So they're all not only testing or claiming to test for something, they're cataloging and taking DNA information and sending this back. Okay, well, so
Yes.
let's get into that then, because this is the really interesting part about this that you are highlighting as well, that there is a lot more than just looking out for your safety and medical concerns. This information was being sent to DOD, to Google, so get into that for me and what that means.
Yeah. So that was one of the things that woke me up too, is so many things right at the beginning that overlapped. It's kind of hard to describe them all in a short period of time. I think that's why I get nervous every time I go live. So the contact tracing part started very early on, and it started in the hospital. There were like social workers that would come in, and volunteers would come in and help, and people that were being laid off because no one was at the hospital, would volunteer their time to help with the effort for the pandemic, and they would, the contact tracing started. Well, for something like HIV, we would not collect, names or phone numbers. It would be up to the patient to call someone and say who they came into contact with. So it was new that this contact tracing thing happened. And now everyone that you have come in contact with, everyone you work with, anyone you drove by, anyone you've been within 6 feet of, then becomes part of this contact map. And that really woke me up, because I thought this is highly unusual, and this is supposed to be protected information.
Right.
There's all sorts of laws about, what kind of information you can share, what kind you can't. I mean, so to have all of these non-patients, they're not even at the hospital, suddenly their names, their addresses, their phone numbers, maybe their email, if that's their contact, is going to be sent to the CDC and put in a database. I thought, wow, that is incredible. Isn't that breaking laws? And so I went to like the AHIMA forum to see if they thought so. And there was all sorts of talk about, oh yeah, we're going to have to amend HIPAA so that we can allow ourselves to do this.
Wow.
Yeah, and part of the COVID-19 registry was Palantir was a part of it, COINTELPRO, Google, who else? Epic. And Epic is part of the medical record system across the whole United States. It's one of the main programs, and they do use AI. It's built into their program. 3M is another one, and they use AI. It's built into the coding program. So and then Palantir has different programs that like Foundry and Tiberius that hospitals use to monitor data. And then Operation Warp Speed used one of those programs to collect this contact tracing data to figure out where to deploy the vaccine.
Yeah. So what's interesting here is that I'm going to read what you wrote or what you said in one of these discussions. So you said the Health and Human Services basically said that hospitals won't get their insurance money unless they send this data to the HHS. But then, as you highlight, that then subsequently gets handed off to DARPA, to research and development, DOD, CIA, Google, and you argue even the Chinese government. So go into that.
Well, that was part of the COVID-19 registry, and then also, so Whitney Webb covers this better. She did a whole article on the HHS Protect system. So HHS Protect was a program that was started under Operation Warp Speed. HHS was working with DARPA and DOD under Operation Warp Speed. This is the contact tracing map that they use to deploy the vaccine. And as she points out, they targeted where to deploy the vaccine based on financials or ethnicity. So they even Bill and Melinda Gates are on record on video talking about how we're going to make sure the blacks get it first, and just stuff like that. So that was all under Operation Warp Speed, but this is based on your medical information, the contact with people who had COVID-19. So anytime anyone is in a hospital or they see their doctor or anything, there's codes that are going to go on that record. Well, there's ones that the doctor doesn't need to say, the nurse doesn't need to say. It's just called social determinants of health. They're not a diagnosis code. There's no money attached to it. They're just informational. And that is where the, unvaccinated, vaccinated codes came from. So to track who was vaccinated and who was unvaccinated, there was actually a different code update that was made later. And there's codes for if you've been in contact with someone with COVID-19, there's codes for if you're unvaccinated, there's codes for if you're vaccinated. And then they have AI that's built into these programs. Like in medical coding, they do have AI that can do the job of a medical coder for very simple coding for exactly that sort of thing. So it can look at a census or a list of patients or a list of people, and the AI would be able to do this, to look at a list of people and see, who has this code attached to them, who doesn't. And the AI would be like, well, I don't see this in the information, so this is the code that I would automatically assign. It's called computer assisted coding, and the AI would just assign it. And if the hospital has a process set up for it, then that could actually go on your medical record. So they use these databases, like HHS Protect had to send certain information or they would not get their COVID-19 money. I need to look into the actual fine print on that, but that was part of the program because hospitals were talking about this is a massive amount of information. We don't want to have to give this out. And I do know that even before the HHS Protect system, there were programs running from the Hospital Information Management Department where I worked, where we would have to collect certain bits of information and send that to CDC or send that to HHS. So it wasn't abnormal for us to have to grab certain amounts of information every single day and then extrapolate, just certain codes that they're looking for and then send that to an outside regulatory agency. But with HHS Protect, it was one of the ones that was attached to money. I don't know if that was, I don't think it was Medicare money. It may have been. That would be the easiest way to do it. I don't want to misspeak on that.
I appreciate that. Well, but I think what's interesting, as I understand it, is the codes themselves are ultimately, in at least one way, designed to kind of anonymize, right? So it's not, but yet this seems to be kind of turned around into being the exact opposite, using those codes.
Right. So like cancer registries, we're supposed to strip personal information out before. So it's just supposed to be about the diagnosis. It's not about the patient. It's just, we have X many people in America and X many people of them have this kind of cancer. And you can do that across the world. And so it's just a way to track, do different places have different occurrences of this? It's a way to figure out if there's a problem. It's supposed to be a way to find if there's an indicator of a issue going on, is what you would hope that they would use it for.
Yeah. And yet now we're in a position where it's the exact, it's obvious we know our government's been cataloging damn near everything we've ever done as much as it can for a long time. This is just one more aspect of that.
They had meetings. This COVID-19 registry, they had meetings that were documented. I have articles that are cited in my book about how they were talking about, well, we need to get more and more information from people. Like rather than talking about we should protect their privacy, we should uphold all these privacy laws. It was about, we need to collect more and more and more information.
Right.
And that suddenly became the norm. So that it was just one more thing that totally changed in healthcare with the pandemic.
Yeah. And I think your overview on this is, I think, absolutely accurate. This is much more than just due diligence and overcompensation to make sure we're safe. And this, we should also highlight, as I know you've discussed, that social contact tracing is just one aspect of I think an avenue to get the same information. But let's remember, as Whitney wrote here, Google and Oracle to monitor Americans who get Warp Speed's COVID vaccine for up to 2 years. Now, this was Moncef Slaoui at the time, who was the leader of Operation Warp Speed, Trump's program, and that ultimately he was very clear about this, that this was not because of you, that you were sick, or because this is, if you got the shot, the government using Google and Oracle were going to be monitoring you for both efficacy, but also because of looking for, they claim, adverse events. Here's actually the article itself from Wall Street Journal, where it says tracking systems will have to be incredibly precise. This is 2020, to ensure that patients each get 2 doses. That's the first argument. You want to make sure that you get what you're supposed to get, but it goes and to monitor them for adverse effects. And it says Operation Warp Speed has selected the medical distribution company McKesson and cloud operators Google and Oracle to collect and track vaccine data. So most Americans are still not even aware that this process was happening, and I argue probably still ongoing, because it kind of got conflated with the idea of contact tracing around whether you were sick. This is anybody that got the injections, and to your point, arguably probably anybody tangentially connected to them.
It's both.
Right.
So, and what I find, and another thing that woke me up too, what I find really odd is, while they say that, because they were also talking about vaccine passports, and they had, you couldn't fly or you couldn't work if you didn't have a negative PCR test for a while. So they were obviously tracking. The whole point was to track the COVID-19 diagnosis. And then the point was to track if people were vaccinated or unvaccinated. Well, in 2021, we didn't have a code for if you were vaccinated or unvaccinated yet.
Right.
But they had been working on Operation Warp Speed for a year. So the time to come up with a code for something like pharmacovigilance or a vaccine injury is in the clinical trial stage while they're working on it. That's one of the things that they use this statistical reporting system for, is in the clinical trials. Mm-hmm. There's sometimes when patients will come to the hospital and they're in a clinical trial, and we have to put the clinical trial code and then whatever is their diagnosis that makes them part of the clinical trial on that. And then it gets billed through the trial budget rather than sent through insurance. So I'm sorry, I got off track there.
No, it's okay. That takes me to the point that you were making, is that ultimately you can see that this was done, just like all the rest of it, sort of outside the cycle in a way that was detrimental, and ultimately for an interest that doesn't seem to be about helping people at all. And I think that's what all of this kind of seems to be coming back to, is that all these choices were done. And throughout the entire process, the argument being that we're just in so much danger, there's just so much going on, and looking back, that even wasn't the truth, but we're done under that guise, when really I can't help but see that every single one of these choices were, it's like, if you tried to make this as dangerous as possible, I don't think you could have done a better job, and that's kind of how I see this all ending. And I wanted to highlight as well, unless you have a comment.
Oh no, I was starting to remember what I was talking about, in that the code for the adverse effect and I was talking about 2 different things. That's how I got confused. So we were talking about
all the time
versus vaccinated and unvaccinated being tracked. Well, in 2021, we didn't have that. We had codes for COVID-19, and the code for being vaccinated or unvaccinated I don't think it came out until 2022. And so when patients started to come in with vaccine injuries, there was no way to report it. The code was not there. And it wasn't that they didn't have time to think about it. So to me, this was very incredibly deliberate. I mean, on top of that, they don't educate doctors to even recognize what vaccine injuries would look like.
Of course.
So when they see someone coming in with an injury, they recognize it as the disease. So if they see someone coming in with sepsis, they recognize it as sepsis. They don't put the 2 together because they're not educated that way. Right. So that was what helped me, was looking at that information first so that I would recognize that. But it wasn't something I could report. It wasn't being recorded at the time. So they're talking about vaccine passports, and I can't even really tell who's vaccinated or who's not until they volunteer the information. And there's no code for it. There's no way to report it. To me, it seemed entirely controlled from top to bottom, because it's not like they didn't know to track it. They had been tracking they'd been doing the contact tracing thing, and they can't track vaccines, and they're doing them through the drive-through, where there's not going to be the same kind of electronic record system as if someone were to go into a facility of any kind where they have a computer right there and they can just put everything in the system, and then those systems can talk to each other to make it easier to have this vaccine passport thing. No, instead they send them through a drive-through and they give them a piece of paper, and so we can't tell when the patient comes in if they're vaccinated or not. So they kind of blinded physicians right there too. I mean, because the patient had to be awake enough to tell them. I mean, there was definitely some cases where patients died before they got to the hospital, and there's no way to know.
Right. Well, I mean, obviously, I think it's very, looking at this from the potential criminal, and I say potential to be objective, I think it's obviously criminal, but the potential criminal side of this and the intention, you can argue that it's self-serving to make sure that it's impossible to know, because obviously then you can't prove one way or the other. And I think that's an interesting aspect of this, that I genuinely think that going back to like your point, the pharmacovigilance, which, by the way, if you don't know, is the term out there watching, the term for the tracking, the part we discussed with Moncef Slaoui, Oracle, and Google, and the tracking of people getting the injections, both for adverse events, but just in general. And I think, this is already happening in a way that didn't necessitate that system. And that's because of other surveillance we have, because of other tracking, possibly even your phone. And I'll actually, to kind of wrap up here, I think one part that is something we shouldn't dismiss, as I know you've talked about as well, is the other aspects of this, the possibilities, I should say. Now, I'm of the mind that I don't think I can prove, or I know I can't prove that any of these things are necessarily happening, and for the podcast being something that might have been in the injection, something that might have been a part of the injection itself, like one of these where they had the RFID chip attached to the syringe, not in the shot, that was then used. And that's all these different levels of this, or as she highlights, or we discussed with Whitney, exposed warp speed with Whitney Webb, chips, gels, and sensors on the way. And then, well, that's the main point, that these are like the gels themselves that actually have the same kind of smart nanotech kind of concept. And so it's interesting to think about, just as a hypothetical, like maybe they didn't need these tracking systems because of this kind of stuff, or any number of overlaps, because the point is, this is something that directly ties to him, Moncef Slaoui, Warp Speed themselves, and even the Gates Foundation, very much pushing within the context of this conversation, bioelectrics, vaccine patches, injectable nanotech conversations. This was leader of Operation Warp Speed, is adamant about implantable biosensors. I mean, this is all coming out right along the same conversation. And I just found that very interesting, even just the idea, as Whitney writes, the eugenicist mindset propelling Operation Warp Speed. The idea that just maybe there's some other reason for that. But anyway, just the hypotheticals, and you can comment on that if you'd like, it's obvious to me and everybody else, I think, with the willingness to be objective, that a lot of what happened here, at the very least, was about experimentation to find out what happens with X, Y, and Z. I also think, as I think you do as well, that it's much, much darker than that. Now, if you'd like to talk about what you think in that regard, and, kind of wrap up on some final points, what do you think the darker agenda is here? Why is all this happening, in your opinion?
In my opinion?
Yeah.
Well, a lot of people ask me if it's money. And there's definitely an incentive for the hospitals. I think the people in the hospital, the reason why I call it a cult in my book, My Life in the Medical Cult, is that I don't think everyone in there went in there to murder people. They're murdering people for profit, but that's not what they went in there to do. I think there's a lot of people, even in a lot of these government organizations, maybe even in politics, that, they think they're in there doing a good thing, but they have just been totally indoctrinated into thinking the wrong thing. And I think the people behind this, I mean, it's clear the people, but I looked for the reason why I wrote the book was there was obviously something going on, and there's obviously something more than just profit. I mean, yes, the hospitals were intentionally driven into almost bankruptcy and then bailed out with the CARES Act. And then they started to make all this money after the CARES Act, and then all the protocols, and so it all just worked out marvelously for them. So I thought all of these people who are involved in the finances behind what created these codes, and is obviously how it's being tracked, there's something behind this. It's not just money. And so I went down the rabbit hole, and I did find eugenics is behind it. So I totally agree with Whitney on that. And I do talk about that in the book, that's ultimately where it comes from. I mean, it goes up to the WHO, it goes up to the WEF, and I think it ultimately is that eugenics has been rebranded as transhumanism.
Yeah.
And I think the vaccines were designed to harm people. I think they, like you said, they were an experiment. I don't know if they were trying to experiment on how fast they can kill people or how slow they can do it. I mean, that's anyone's guess. To me, I think the ultimate goal isn't money. I think it's control. And I think the agenda with the vaccine is to separate people from their soul. I know that's getting a little spiritual there, but with the personality changes and the mental issues and the I've just heard so many people, even some of the records even mentioned things like, you know, I feel different anymore. That's not the same person.
Mm-hmm. Well, I would say that there's nothing that we should shy away from considering, right? I mean, I think at the end of the day, what we're talking about is obvious malpractice, obvious criminal activity, obvious experimentation. And so we should be considering, I mean, the one point that I always make in this, and I don't think what you said is crazy at all, but I think that what's interesting is the real question in any of these contexts is not whether you think what they're doing is possible or real, but whether they think it's possible or real, or whether they're willing to try to find out. And I think that's the real history around how the government and governments, but specifically the U.S. government, has experimented on its own population so many times. It would blow your mind if you truly understood it. The one that I've talked about a lot is the verifiable reality that they've admitted at least once in the past to experimenting on American citizens, whether it was biological or chemical, 239 times without their awareness. Operation Sea Spray in San Francisco is an often cited point because it is publicly acknowledged, but it's rampant. And
well,
I think
it's coming at us from every angle. It's not just the vaccines. It's in the air, it's in the soil, it's in the food, it's everywhere. It's unavoidable. It's the 5G, it's everything. We're just being attacked on every possible level. There's no way that they actually have our best interests at heart. That's just not possible. So
I wholeheartedly agree. I just they being the hierarchy enslaving you, the governments, the social engineers, the regulators. I mean, from every possible angle, it's clear that things are being allowed. Like whether we're talking about glyphosate or endocrine disrupting chemicals in general, or fluoride in your water. I mean, it's provable to this day that these things are not just a problem, but are almost intentionally there for clear, dangerous reasons. And I hope people are looking into these things more. And I'd like to end with
challenge them. They won't back down. That should show you something, that they will challenge you to fight to keep the poison in the water. That should tell you something.
Exactly. And that's exactly the fluoride point that I've made, is that it's recognized that right now you've got the government in court defending trying to fight legally to keep something that they've admitted in this court process is hurting you. And that's the reality of the fluoride trial right now. It's actually mind-blowing. I'd like to end with you're giving a shout out to your upcoming work. Make sure let people know where they can get your book when it comes out, or give the information that's going to be coming out. Make sure you check out her book, because this is I'm looking forward to reading it myself, because I'm sure there's going to be a lot of stuff in there that we can't piece out through an interview. And she'll know this, again, Zowe Smith, whistleblower, medical coder, somebody who has the inside word on this. As I said in the beginning, I love the way you framed that, sort of the SimCity view of all of these different overlapping agencies. It really does give a good perspective of what your job has allowed you to see. So go ahead and end however you'd like with a shout out to your upcoming work and the book itself.
Okay, thanks. Yeah, so I'm in post-production right now. I got censored multiple times with Truth Publisher, self-publisher, editor. That's a whole big thing. It's been a year-long fight just to do that. Mm-hmm. So I'm back at it just myself. Having not worked for a few years, I can't do traditional publishing because the funding is an issue. So I'm just editing myself, and I'm looking for reviews, and then it should be able to be out later this summer or fall at the very latest. So it's called My Life in the Thrill Kill Medical Cult, because I wanted you to understand that they're killing people. Mm-hmm.
And I don't think cult is too hard a word, quite frankly. I mean, clearly there's a mindset here that is causing people not to be able to see what's right in front of them. So I think
a lot of people think that it means like Illuminati, or that I want to get into talking about other kinds of cults. And what I mean is, no, this is, the Rockefeller eugenics based cult that people have been indoctrinated into with this, the allopathic medicine and how that's actually very harmful to people, but they think that it's helpful. And so it's just this weird, you think you're going to the hospital to get well, but actually they're going to keep you sick, sort of a thing. And that's sort of like why it's a cult. They don't even know that they're in a cult, but that's how it works.
They usually don't. And that's how cults typically are, right? I've made that point many times where, you look back at people that were in that moment, they'll defend it to the death. And later they look back on some documentary and they're like, I don't know. I don't know what I was doing. That's usually what people are in that position. It's this, this is why the whole mass psychosis or psychosis or mass formation psychosis. Yeah. That's why, as much as that's not meant to kind of remove their accountability, you can clearly see some level of that's happening, that people just are falling in, So that's why I really think your work is so important and courageous. And so thank you for what you're doing. And let's make sure we connect again once the book comes out and reach out for anything else that's happening. Because I think people, make sure you follow her work. I'll make sure to include her information links below, because it'll be some more coming your way. So thanks for being here today.
Yeah, thanks.
And as always, everybody out there, question everything. Come to your own conclusions. Stay vigilant.